So I'm the next speaker, Art Slutsky from Toronto. And I'm going to talk about ventilator-induced lung injury, one of my favorite topics. There you go, that's really me. So let me first start by showing the conflict of interest disclosure. I've talked about this already. I think particularly important, obviously, is I'm on the advisory board for McKay, so just that you bear that in mind as I give my talk. So what I'm going to do over the next 20 minutes is very briefly talk about ventilator-induced lung injury, what are some of the factors that cause ventilator-induced lung injury, talk about biotrauma, again, just one or two slides. Ask the question, do we need or why do we need any new modes of ventilation? You know, we have the ARDSNet trial. Do we really need this? And give some evidence that the ARDSNet strategy is certainly not perfect by any means. And then talk about the potential benefits of NAVA in this regard, and that's because this is a NAVA conference, and I'll explain what I mean, and then conclude. So in terms of the physical factors aggravating lung injury, there's a number of physical factors, as you all know. If you overinflate the lung, you can get something called volutrauma or barotrauma. It causes increased vascular permeability, causes leak, causes damage, and barotrauma can get air leaks. We all know this, known for many years. There's also at the other end of the spectrum something we've called atelectrauma, when you ventilate lungs at relatively low lung volumes, where lungs start to collapse and reopen, other mechanisms as well. And this mechanisms for this relate to probably effects on surfactant, but as I said, also effects probably on lung collapse and reopening. So these are the physical factors that can cause or aggravate lung injury. There's also something called biotrauma, which I'll explain in one slide, and that's, as I said, we've known with mechanical ventilation that there can be biophysical injury. So the kind of injury I talked about with shear, overdistension, changes in intrathoracic pressure, and these can lead to effects that we've known, including decreased cardiac output. However, there's also a mechanism of biotrauma where if you injure the lungs with the ventilator, you can actually cause release of various mediators into the lung. These mediators can do a number of things, including injure the lung itself. There are some chemoattractants that can attract neutrophils to the lung, which can then add further damage. And potentially, most importantly, is if these mediators can get into the systemic circulation, they can lead to distal organ dysfunction. They can lead to MODS and eventually to death. And the reason this is potentially important is that if you look at patients with ARDS, the ones who die, most don't die of hypoxemia. They don't die respiratory death. They die because of multiple organ system dysfunction. So this may be the mechanism. So what we're doing with the ventilator may actually, we're keeping patients alive short term, but we may be killing them long term. And that's why biotrauma is potentially very important. So that's sort of the problem. Is there evidence that ventilator-induced lung injury is important? And you're all familiar with this study. This is a classic study. If you look at the number of times this paper has been cited, it's been cited almost 3,000 times since it was published in the year 2000. And what it showed basically is that a low tidal volume strategy with 6 ml per kilo decreased mortality from about 40% to 31% by simply changing the ventilatory strategy, by simply addressing the question of ventilator-induced lung injury. Interestingly, in this group here with the smaller tidal volume, oxygenation wasn't any better, so that wasn't the mechanism. You look at barotrauma, virtually the same between groups. And these investigators suggested that perhaps it's biotrauma, perhaps it's release of mediators that explains the mechanism. So we have the answer. So isn't this sufficient? Why do we need anything else? Well, that gets at the question of, do we need new strategies for minimizing ventilator-induced lung injury or its consequences? By its consequences, I mean the systemic effects. Well, there's a couple of studies that have addressed this, and just because of time, I'm going to just show you one study by Salvatore Grasso. And what he did was he set out to examine the question of whether the ARDSNet strategy, which, again, I'm not going to put on here, but I think you're all familiar with a PEEP FiO2 table, tidal volume of 6 ml per kilo, whether that strategy could still lead to overinflation of some lung units. One of the issues in mechanical ventilation, if you've got a very severe lung, how are you going to pick one strategy that works in all 300 million alveoli? So this question was, could there be some overdistension? So he studied a relatively small number of patients, 15 ARDS patients, and compared the ARDS strategy with the strategy based on something called the stress index. And again, because of time, I don't have time to go into this. The stress index is a method of that Marco Ranieri and I and a few others developed a number of years ago to try and assess on a breath-by-breath basis whether the ventilation strategy could potentially cause lung injury. And the idea is looking at the shape of the pressure time curve and values of a parameter called B. If those parameters are less than 1, it was likely the lung is being recruited and de-recruited. It could lead to adlich trauma. If that value of B was much greater than 1, likely there's overdistension. For now, that's all that's required, and we can talk about this at some other time. And then what Grasso did was measured mechanics and various cytokines. So here is data from the 15 patients. This is the stress index on the y-axis. Remember, 1, if it's 1, then the lung is not being subjected to stresses. If it's over 1, in this case over 1.1, then it is. So here in a number of patients, you can see the ARDSNet strategy is applied by the ARDSNet group, even though it was somewhat lung protective, still likely was leading to stress in the lung. When they changed the PEEP level, they kept the tidal volume 6 ml per kilo in this study, they were able to lower the stress index, because if you lower the PEEP, obviously you're going to have less distension. And here's the value of PEEP that they used. And I'm just going to give you one data slide from that paper. This is plasma levels of IL-6. This is a mediator, as you know, been shown to be increased in biotrauma. And here's the IL-6 levels in the ARDS network. When the patients were ventilated with the ARDS network strategy, you can see, forget the exact value, that's not important. When they're then ventilated with the stress index, with a strategy based on the stress index, IL-6 decreased, and this was statistically significant. So I think the important point here was that the ARDS network strategy, although beneficial, clearly is not it. It's certainly not perfect. No one would say it's perfect, but I think there's some evidence for this. We don't know whether plasma IL-6 is in itself very important or not, but the fact that in those patients in which the ARDS strategy was used were higher IL-6 levels, I think is highly suggestive that in fact there is some injury. And there's other studies looking at CT scans showing that with the ARDS network strategy, you can have overdistension of some lung units. So how can we minimize detrimental consequences of mechanical ventilation with, over and above the ARDS network strategy? Well, there's a number of approaches. We can use physiological measurements to guide the ventilatory strategy. As you know, the pressure volume curve has been looked at for a decade and a half, or a couple of decades, in fact, as suggested as maybe being useful. One approach is to use pleural pressure, measure transpulmonary pressure, and there's a study in the New England Journal by Talmore and colleagues that looked at oxygenation. Looked pretty promising. They're starting a large-scale outcome study looking at this, so that may be useful. The stress index is one I've mentioned, which could be used to look at outcomes. Imaging, electrical impedance tomography has been suggested as a way of looking at the lung to see whether the strategy you're using is causing overdistension. And different ventilatory approaches. The prone position, as you know, high-frequency ventilation, and NAVA are possibilities. And of course, extracorporeal gas exchange. There's certainly a number of groups now looking at, if you want to decrease ventilator-induced lung injury, well, gee, one pretty neat way to do it is to get rid of ventilation completely. So this is a possibility. I'm going to focus here on, obviously, NAVA, because that's what the topic today is. That doesn't mean that I think this is the only or the best way to do this for ARDS. But since we're here to talk about NAVA, I'm going to focus on this particular mode for today, just to give you a few tidbits, a couple of studies that suggest that maybe there's some advantage. So this is a study that Lucas Brander did when he was in Toronto a number of years ago. He came from Switzerland for a couple of years. And I think a pretty interesting study. The hypothesis was that if you let a patient control their own tidal volume, that might limit ventilator-induced lung injury. And the patient in this case is rabbits and animals. And here the rationale is as follows, and I think this is important. If you think about it, Christer showed a slide with lots of reflexes from the lung. There's lots of nerve endings in the lung, that there's lots of reflexes that control how we breathe. You know, you've heard of the Herring-Breuer reflex that limits the size of a tidal volume, more so in some animals than in humans. So why do patients with ARDS, who have sick lungs, why do they have rapid shallow breathing? Well, one hypothesis is that they take a breath, you have the receptors triggered in the lung that say, whoa, if you take much more of a breath, you're going to cause injury, and therefore limit the injury. Well, if that's the case, then in fact these receptors are helpful and help limit the size of a tidal volume. Then with something like NAVA, where you can control the tidal, where the patient controls their own tidal volume, it might theoretically be useful to use NAVA in patients with ARDS. So that's the hypothesis. I should point out, it's very important that it's only a hypothesis. I think it's a reasonable hypothesis, but you could argue that in ARDS, where you have such bad lung disease and lots of inflammation in the lung, maybe the innate mechanisms you have to protect the lung are broken, and that may be the case. So this is not a done deal that this is the right way to do things. So in this particular study, we studied rabbits, had tracheal acid installation. It's, I think, a pretty good model of acute lung injury that mimics what happens clinically. Patients often aspirate and they get ARDS. We had 3 groups of patients, of animals, those treated with a tidal volume of 15 ml per kilo, 6 ml per kilo, like the ARDSNet study, or NAVA. The animals were anesthetized and ventilated, as I mentioned, stable hemodynamics before proceeding. And then we induced lung injury. The details here, it's a common method, basically paralyze, give the animal some hydrochloric acid, and the details are given here and in the paper. And then we ventilated them for 30 minutes, and then if they had a PF of between 80 and 200, we proceeded to randomization. And that was because if the PF was much lower than that, we thought they're likely going to die before the end of the experiment. If the PF was much greater than that, they probably didn't have very much injury. The key here is we didn't do the randomization until after that. So we excluded 3 animals that didn't go on, but the randomization occurred after, so it's an intent to treat analysis, even though it's a small physiologic study. So here are some of the results. This is the tidal volume. And as expected, when we set tidal volume of 15 ml per kilo, we got tidal volume of 15 ml per kilo. Set 6 ml per kilo, we got 6 ml per kilo. This is the interesting part because we didn't really know what the tidal volume that these animals would pick. You know, this is with NAVA. And you can see here they started with tidal volumes of about 2, went up to about 3 mils per kilo in this particular case. I should point out, given the way we did it's important to see how we did the injury, where we gave some pancuronium. It takes some time for the pancuronium to wear off. So these early measurements of tidal volume may be affected by the paralysis, by other things. But I think that this steady state here is reasonable. So that's tidal volumes. That's the tidal volume that animals want when they have this type of injury the way we induced it. Here are the PEEP levels. You can see with the various forms of ventilation. PEEP levels were essentially the same for NAVA and for 6 ml per kilo. And here are some of the results: PF ratio and wet to dry weight ratio. So let's look at PF ratio first, which is on the left, 0 to 6 hours. The PF ratio is on the y-axis. You can see, not surprisingly, the PF ratio for the 15 ml per kilo group, which is causing more injury, was quite a bit lower than the other groups. And the other 2 groups were similar. So that is NAVA. If anything, the NAVA values were higher than the 6 ml per kilo, but very, very similar, and certainly no statistical difference by the end of 6 hours. Here is the lung wet to dry rate ratio, a measure of how severe the injury is, how much fluid there is in the lung, how much increased alveolar capillary permeability there is. And we looked at this in terms of the dependent right lower lobe or the non-dependent right lower lobe. And as you can see, this is the control, a healthy control. Wet to dry is about 4. With 15 ml per kilo, the wet to dry is about 8. And then it went down with the 6 ml per kilo and down further with NAVA. And that was true for the dependent and non-dependent regions of the lung, suggesting that the wet to dry rate ratio certainly lower than 15 ml per kilo and looked like we're lower than 6 ml. Here is some IL-8, another cytokine, actually a chemokine, that a chemoattractant to the lung. This is plasma IL-8 concentrations. This is after 6 hours. You can see 15 ml per kilo, very high IL-8. lower with both other strategies. And the same we looked at particularly at various organs to see what the IL-8 concentrations in these organs was. These are the non-pulmonary organs. And in all cases, 15 was much higher. And in some cases, NAVA was better than 6 ml per kilo. In other cases, it was the same or certainly never worse. So these data suggested that maybe the hypothesis is correct, certainly in an animal model, which is much less complex than humans with ARDS. So that's animals. What about humans? And there have been a number of studies that have looked at NAVA in ARDS. And I'm just going to give you results from one. You'll see why in a moment. So this is a study by Terzi and colleagues where they looked at the physiologic response to varying levels of pressure support and NAVA in patients with ARDS. They studied, again, a relatively small number of patients, but this is a physiologic study. And, excuse me, they looked at pressure support and NAVA in a random order, and they used 4 levels of assist, up to from 100 to 160%. And they measured tidal volume, they measured a Synchrony index, they measured a number of other things, but that's what I'm going to focus on. And here are the patient characteristics. I don't expect you to look at this. The key is just these are patients who had ARDS that are caused by primary causes, lung causes, largely pneumonia and intraalveolar hemorrhage. Here's the tidal volumes, the level of assist on the x-axis, tidal volume on the y-axis. And here you can see with pressure support, as they increased the pressure, the level of assistance, tidal volume, not surprisingly, went up. With NAVA, there's 2 types of NAVA, and forget that detail for the moment, but with NAVA, you can see that increased level of support, NAVA, the tidal volume remained essentially constant. And it's interesting, it's about 6 to 7 ml per kilo. It's interesting because with the ARDSnet study, they picked a 6 ml per kilo somewhat arbitrarily, but actually reasonably close to what we've seen as well in some patients, what they receive. So no effect. Here is the interesting piece in terms of the asynchrony index. And you can see that the asynchrony index, lowest with NAVA, but increased with pressure support as the assistance increased, and above this threshold that Paolo talked about of 10% at the highest levels of pressure support. So you can see that in this case, NAVA appeared to be useful in terms of maintaining a tidal volume, potentially decreasing level of assistance, although clearly depends on what level of pressure support was used. Well, why might this be important? Well, I'm sure you all are familiar with this study from Papazian published in the New England Journal about 1.5 years ago, in which they, quite a controversial paper, which they suggested that the use of neuromuscular blocking agents early in ARDS for the first 48 hours could actually decrease mortality. And here's the Kaplan-Meier curves from that study. And you can see here, this is the neuromuscular blocking agent, mortality curve, the Kaplan-Meier curve. And here's the placebo. And this difference was statistically significant. So pretty big difference, relatively small number of patients. And as I said, somewhat controversial. Does neuromuscular block for just 48 hours really have this effect? Why is this important for what I'm talking about today? Well, I wrote an editorial about this paper in the New England Journal and suggested a number of possible mechanisms by which, if it's true, by which neuromuscular blocking agents could decrease or impact mortality and improve survival. And the key aspect, I thought, or one key aspect, related to the synchrony. And by paralyzing patients, there's a lot of good things and bad things. One thing you're able to do is you can certainly synchronize, in a sense synchronize because there's no efforts. You're not really synchronizing to their underlying drive, but you don't have dyssynchrony, you don't have the double triggering. Double triggering can lead to potentially worse ventilator-induced lung injury. So this is just hypothetical, what I've tried to show you now. So in summary, there are different forms of ventilator-induced lung injury: barotrauma, atelectrauma, volutrauma, and biotrauma. The ARDSnet, I think, is a reasonable gold standard to use clinically now, but it's certainly not the right answer. It's certainly not how we're going to be ventilating. I hope it's not how we're going to be ventilating patients in 5 years from now. Actually, when the study came out, I sort of predicted, but by 2010 that some other study would have shown a better pattern. We haven't yet. But I hope that in another 5 years we're not there. That's only one approach, and it's certainly not the best approach, however you define it. So we have to improve upon it. There's multiple different approaches that I mentioned on that one slide with monitoring, with changing ventilation pattern, with ECMO. But I think NAVA certainly has potential. It has potential. Is it the way to ventilate patients with ARDS? I don't think so for today. It's one way. And you're going to hear from Antonio later. He's going to talk about NAVA and ARDS. But it certainly makes some sense. But we clearly need more studies to know if it's really going to improve outcomes. Thank you very much. And I'm not sure I'd be able to take questions because I think I'm a little bit behind. One question. We'll take one question. So thank you. The microphone. This question up at the front.
You don't have your microphone?
Up, no, right,
No,
right, no,
Susan. No, I didn't want that.
Yeah, my question is about the study that you did with the rabbits and with NAVA, and you had a set PEEP level. Did by any chance you record the EDI peak and minimum values during that study? Do you know? The reason I'm asking is because I've heard that, like in neonates and peds, or neonates specifically, they tend to have a higher EDI min, and I'm wondering if ARDS might cause a higher EDI min because they're trying to increase their FRC.
Yeah. So you know what? I don't remember if we did that in that question, but we have somebody who can actually answer that question right behind you. In babies, not even in rabbits.
So I'm Jennifer Beck from Toronto. So I can't comment specifically on that study. One thing you forgot to mention, Art, is that the two volume-targeted arms were paralyzed animals,
Yeah,
so there is no EDI activity in those two arms. NAVA is the only one where we had spontaneous breathing. And what I can remember is we had a NAVA level that was selected at the beginning, and we didn't touch it, as far as I remember.
During that study, no.
No, and then, but I don't think we reported the tonic activity. There's another study with the exact same model where we looked at the impact of PEEP on the tonic activity. So that's by Jean-Christophe Allot in critical care medicine. And in that study, when you lowered the PEEP right after the lung injury, you had a high level of tonic activity. As you increase the PEEP, we could actually do a dose response, and the tonic activity was able to come down. And at some point, we gave so much PEEP in the rabbit that they stopped breathing.
Jennifer,
so there is a dose response.
I asked you specifically, wonder if do you have anything in babies?
Yeah.
Because in animals, I think it's true. But what about in humans?
So in an intubated baby in the pediatric ICU setting, and a baby that's just about to be extubated, we actually changed PEEP levels very briefly. We lowered it from, they were on a PEEP of 5 to 0, and you could see the same response in them. And they actually had quite a significant amount of tonic activity. It was about 12% of their peak activity, which is quite high, even though they were on a prescribed level of PEEP. So we see it in the babies as well.
And Susan, I think one thing to put in there is that when you have the in the babies, it's what I think is you have the activity. So the thing, you can turn the knob, take away the PEEP. You will see the response. If you don't see the response, well, you can rule out. They will not recruit with tonic activity. So if they don't do it, I mean, you can see it. So you don't have to guess. Like it's kind of the nice thing is when we work in the animal lab. Like in this study with Lucas here, for example, I think the PEEP was titrated to the highest tolerable blood pressure. We said that blood pressure couldn't drop over a certain level. So in 6 ml and in NAVA, there was like a titration of blood pressure kind of related PEEP all the time. They follow the same trend. But the thing was, we had in the beginning to get PEEP up with NAVA because otherwise we would have the tonic activity would be hysterical. So, and then he matched this kind of setup in the other arm. So it's kind of like the animals do recruit, and so does the babies. But I've also seen babies where you take away the PEEP and you don't get an increase in tonic activity. And why that is so, I can't explain, but at least you can see it. So if you have the response and you see take away the PEEP and you see tonic activity goes up, well, now at least you can hypothesize that this is a de-recruitment. You give the PEEP back and they don't have to recruit themselves.
Theoretically, we saw in the low study, if you see that, you think that maybe this is a way for the patient to decide what PEEP. You know, I talked about what side is the tidal volume. Could they decide on the PEEP? In adults, I don't think it's so clear as it is in infants.
But Lucas actually did a human study showing that titration of PEEP using the neural output was actually feasible too.
So I think we're going to go for a coffee break. There's going to be, as I said, a panel at the end. We'll come back here at, let's say, realistically, 11:45.